So, ladies and gentlemen, welcome here this morning on the session of fetal echo. I like Paris for several reasons, because it changed in a way my life, not because I speak French, and to be, let's say, to support your opinion. I could do it also some words in French, but we have, I guess, less than 10 persons who are true French. The other one are, let's say, our fan group from London who moved with us to Paris. Why? Because there are things you don't know, but let's say I started doing some ultrasound and some Doppler 86, 87, and once I have collected around 50, my first 50 cardiac anomalies, I came with a poster to the World Congress of Perinatal Cardiology or something like this, fetal cardiology meeting in Paris. It was 89. And I put the poster there, and then I saw all the people you know from papers. At that time, there was no internet. That means you know it only from Index Medicus and from circulation and other things. I met Laurent Fermot as, let's say, one at that time in the small group known person. And when I spoke to Lindsay Allen and Greg Tavor, they said, you know, if you want to learn screening, there's Laurent is the best guy in the world. I told him, you know, I have seen 50 cardiac problems. It's not bad. He said, yes, we had last week our 1,000. And then I was depressed. But he said, you know, the way is if you perform a good teaching, people will refer you cases and you will reach 1,000. And you are true now. I have by far more than 1,000. And this is why there are many, many things I learned over the years. And this is why I'm very, very happy that we return back to Paris, that you can also show what you have done, not only for the Paris region, for France, but also for the world. Now, with ISUOG, we went this way, and we are giving every year courses, and you have a lot of about anatomy. And you have heard in the previous talk many things I'm going to cover anyway. And once I decided to do the cardiac anatomy and then said, well, it could be easy done, half an hour, I will cover everything, I realized that the 4-chamber view, I will not even finish this morning if I do it. Why? And the difference between the meeting yesterday and the meeting today is that we have also cardiologists with us. Yesterday we had mainly obstetrician. We didn't have any neuroimaging person doing MR or some pediatric neuropediatrician and so on. Why? Because there is also need for, let's say, for a second opinion, for discussion, and for interaction. And we learn from each other. And I'm sure that after my talk, Giulini and Laurent, when we go out, said, it's not true what you said, because this is not called like this. This is called the other way around. But nevertheless, we should at the beginning say that don't be discouraged by fetal heart. It's by far more easy than you think. And this is why the problem is the people like me giving talks make things sometimes very complicated. And when you ask your cardiologist, it is never the diagnosis you have done, because they tell you, no, this is something else. You don't know, this is too complicated for an obstetrician, we tell you. And this is sometimes what I assumed in the past. Some person sitting said, no, I'm afraid I don't see a transposition of the great artery. I see an atrioventricular concordance with a ventricular arterial discordance, which is, for, let's say, if you don't know, this is actually the same word to say transposition but by the, let's say, sequential approach. In other words, we can make things easy, but we can make things also very complicated. Now, if we look at the heart anatomy, I think many of you know already what they know the 4-chamber, what's about, but why is a specialist able to see more within the same plane like us? And I'll show you some tips and how to deal with. But when you look at the heart, we have both atria, we have the ductus and the arteriosus connecting the pulmonary artery with the aorta. We have the aortic arc we have to check. We have the ventricles, we have the septum. But we can also, in the meantime, visualize very well the atrial appendages. We can see also, in some condition, the coronary arteries. We can also detect or demonstrate the proximal and the peripheral arteries and veins, and inferior vena cava, superior vena cava, the branches of the aortic arc, like the subclavian arteries and the brachiocephalic and other things. And last but not least, we can look at the septum and other things. In other words, we are really today at the stage where the secret of all details of the heart is only depending on, let's say, fetal position and the scanning machine, blah, 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 but also on our experience. And the newer machines allow us to see by far more. This is why they excuse the machine is not so good. Believe me, the machines we worked with in the 80s were worse than, let's say, the machines which are today in every small private practice in all over the world. This is why, let's say, in the past at the university, I had a small normal machine in the, let's say, 10 years ago. I could do everything because I was used to have a worse machine. But the difference is that some will have color, some will not have color. So now I will not discuss about color Doppler today because Dari will do it, but I will go with you step by step what I think should be known, and this morning I will cover mainly the four-chamber view because I will be otherwise running out of time. If you look at the upper abdomen, we know that we should check, as Giulini said, the left and the right side before we check the stomach position. And after knowing where is the stomach position, I will recommend you, and I hope that every one of you will take some messages with at home, not only to look at the stomach, but also and mainly to the vessels in the upper abdomen. Of course, it's easy to check that the stomach is on the left side, but you may miss some conditions if you only check the stomach. And then you divide the upper abdomen, and you will see that under normal conditions, the aorta is on the left side of the spine, and just here what you don't see is the small, very tiny azygos vein, and this is the inferior vena cava, which is more ventral and lateral. This here is the umbilical vein connected. What is this? What is this? The hockey stick shape. What is this vein? Sorry? Portal sinus, the left side. You need the time to understand why is this the left side, because the right side will go this way and the left side will go to the left or comes from the left. And this is connected to the left portal sinus, portal vein. Now, what are the typical abnormalities? I show you 4 images. This was a quiz in one of our meetings in Germany. And if you look at these, most of the beginners and some of the experienced will say, these are normal because the stomach is on the left side, and these are abnormal because there is a right-sided stomach. Actually, this one is a normal condition, but look at the vessels now. The vessels have a normal arrangement. In this condition, it is called the cytosolitis, which means the common cytos. In this condition, the vessels are a mirror image change. The two most common conditions is the first one. The most common one, what you see on Monday or Tuesday or latest Wednesday, is the breech presentation, or you have the wrong transducer, and you assume today I will find my next cardiac problem. And the rare condition is a true situs inversus completus. This is why once you see this, check that the fetus didn't turn or you didn't switch on your computer. This is a common mistake that you think left and right and so on. But the typical image is situs inversus completus because these are mirror image change. In this condition, what you see here, you see only because I tell you, and because you should know this, both vessels are on the same side, and it's called juxtaposed inferior vena cava with the aorta. And the stomach is not on the left. The stomach is in middle position. Because if you know that this is right-isomerism, you know in right-isomerism, we'll see this afternoon, we'll have a large liver, and it comes here, and then they realize, oh, the stomach is not left, it's more in the middle. In some cases, we'll have even a herniation of the stomach in the thoracic cavity. And in this condition, I told you before that there is some tiny inferior vena azygos vein. There is an absence of the inferior vena cava, and the venous blood draining from the abdomen will pass through the azygos vein, and this is why it's dilated. And you see vessels side by side. Why is this important? Because in this condition, the stomach is on the left, but you still have these vessels as sign of left-isomerism. Here, it's easy. If you have a stomach on one side and the heart on the other side, it's easy to detect. But it's not always like this. And sometimes you need to know more, and the more means check for the upper abdomen if you have absence of an IVC, or in this condition, you see the stomach, inferior vena cava, aorta. But it's not something you will put the transducer and you see it, because you have to seek for these vessels to evaluate. Of course, it's difficult if you are scanning a routine fetus to say, well, this is right-isomerism, because almost all right-isomerism, they have, we'll see this afternoon, severe cardiac problems. That means once you have seen a cardiac problem, you should check, is the upper abdomen normal? And the upper abdomen does not mean the stomach is on the left. Okay, this is the first part. We move next to the ventricles. We have two ventricles. Many think that right and left ventricle are where the side is, because we have on the right side and left side. But what we have here is that the right ventricle has typical features. And if you go to the autopsy and you watch how the ventricles look like, you see that there is a huge difference between atria and both atria and both ventricles. The shape of the right ventricle, you will see later, is rather kind of more square. The left is long, and there is a typical trabeculation. Characteristically, the tricuspid belongs to the right ventricle. We'll have apically a moderator band, we can see very impressively, and we have papillary muscles and chordae tendineae. We'll see later on, they will attach also to the septal wall. That means once you look at the four-chamber view, you should at least recognize that the tricuspid valve belonging to the right ventricle is lower attaching on the septum, that we have here the papillary muscle which is thickened. And if we compare the length of the ventricles, the apex is built or is formed by the left ventricle, and the right ventricle is a little bit shorter. On the other hand, the left ventricle has a more long oval shape. It has a smooth structure. The mitral valve belongs to the left ventricle. That means once you identify a typical mitral valve, the corresponding ventricle is a left one. And it forms the apex, as I told you before. And the papillary muscle, they will attach always to the free wall. And the septum is without any chordae and any papillary muscles. Now, what you see here, in conversely to the other, find the mitral valve is here. The length of the ventricle I showed you before. And the apex is formed by the left ventricle. Sometimes, you will not change the complete diagnosis only because you assume that the left ventricle, because there are, of course, abnormal conditions where it's not like this, but once you are seeking for signs, this is, let's say, a summary of signs you can use. Now, as you heard before, we'll use cine loop to check the diastole and systole. During systole, the valves are closed with tricuspid, it should be valve and mitral valve, right ventricle, left ventricle, right atrium, left atrium. And during diastole, what we see here, we don't see the true attachment anymore. We see the patent valves here, and we see two separate valves. Even if we have a tricuspid, we see on 2D, of course, only two. And we see here, in addition to the valves attachment, an echogenic dot, which is here, which is the septum primum. We'll see later on. Now, if we move the transducer to a more lateral approach, or if we go a little bit lower toward the upper abdomen, we see here the so-called papillary muscles connected with the chordae tendineae. And typically, on the right side, we'll have this one will be a septal attachment, where on the left side, it is on the free wall. If you think, well, I don't remember this tomorrow, the left is longer, and this is why the papillary muscle, they will go to the wall and they will not reach the apex. And if you forget, the left ventricle is the most important ventricle for the body later on, and you don't have things inside. You have only on the free wall that the valves are open. But let's say the apex of the left ventricle is free from anything. So these are things you see if you want to look for, but it's not something you evaluate on the routine. But sometimes there are conditions you have to know where do I see the papillary muscles. If you have a large VST and or an AVSD defect and so on, and you see one muscle going, one papillary muscle going over this, it's called straddling, and it can be operated. And there are many things you should know that we can see them today on ultrasound. This is here heart open from the right side. And you see that we have one to the an anterior papillary muscle, a posterior one, and this one going to the septal wall, where on the left side we have both going, the anterior and the posterior, and the apex is free, and the septum as well. And I'm happy that Giulini showed you this video clip before, but this is, again, to show and to stress that in doubt conditions, you can recognize this on a cross-section, on a kind of short axis. You have seen when she turned the transducer in one of her last images, showing that you see here the anterior and the posterior papillary muscle on the left side, and the one being here on the septal wall. The atria are more tricky in the fetus because we have on one hand the atrium and on the other the so-called appendage. The right-sided right atrial appendage is more square or broad attaching, and on the left side it's like a finger hook or let's say more shape, more sharp shape. Now what you see here, typically for the right atrium, let's say most of them we can't use prenatally because what we see in the pathology, that the posterior portion is smooth, the anterior portion is trabeculated. You don't see it on ultrasound. In the neonate you may have some idea, but this is not the way we look for. In general, what we check for, that it receives the inferior and superior vena cava and coronary sinus, and in doubt the appendages may be of importance to check the shape. And on the left side, what we see on the left side is that the left atrium, that the foramen ovale valve, it will bulge into the left atrium and it receives the pulmonary veins, and the left atrial appendage can be of help. Now, if we look at here, again, what we were speaking about, this is an atrium getting the lung veins, and this is a normal appearing for chamber view, and this is the left atrium connecting with the left ventricle. If you take a longitudinal view, you see the superior and inferior vena cava, and you see here the right atrium. And sometimes, once you move your transducer a little bit higher to get the great vessels, you see here on the border of the left atrium, but better impressively near the pulmonary artery, a kind of appendage here, very well seen then. And if you want to look at for the right one, you may see on longitudinal view, this is the right atrial appendage as it can be seen. It's rarely needed that you see it, but if there is a condition, I'll show you later on which one, where you have to check for, then you know how they look like. And in general, the shape is quite different if you focus on this condition. Now, if you look at the anatomy of the atrial condition, what you see here is the septum primum with the foramen ovale and the septum secundum being here. It is called primum and secundum due to the embryological development. And we see also behind the heart, that means between the heart and the spine, we see 3-4 things. First, it is the descending aorta. What we see here rarely is some azygous vein. We don't see it because it's too small, but if you want to, you can recognize where it is because you can see it on color Doppler, how it entered the superior vena cava. And sometimes you see from time to time some black vessel disappearing. Again, this is the esophagus during swallowing. The problem is that once you are scanning, you don't think that is esophagus because for you are scanning the heart and you see what is here, a second vessel and disappearing. This is esophagus. And if you go a little bit higher, and this is more tricky, in a higher plane at the level of the lung pulmonary artery is a little bit lower, you may see even the bronchial tree. It may be important if you are scanning later gestation and the fetus is breathing. You think, oh, there is a vessel around here. What is this vessel? And it disappears again. And this is the breathing movements within the tracheal tree. But in general, under normal conditions, you have left atrium, you have attachment of the lung veins, aorta, esophagus, and small azygos. That means you see only esophagus and aorta and spine. Now I'll show you here a video clip. What you see here, this is the small azygos vein, which is not important at this stage. Echogenic dot may be here, esophagus. It's not very important. This is important. It's on the left side of the spine. And what you see here is the right and left atrium. We may recognize in one of the next videos also that there is pulmonary veins here. The trabeculation is well recognized. The tricuspid is lower attaching, and the mitral valve is higher. And the apex is formed by the left. The shape of the left as well. And look at this here, the papillary muscle on the free wall. And if you look at it carefully, you see here that it's along the septum. Another video clip of a normal for chamber view. You see here like two vessels entering the left atrium. These are the pulmonary veins. And you don't see clearly here by this resolution the papillary muscle clearly, but you see the anatomy is absolutely normal. Now let's move to some cardiac problems. What do we assess when we look at the ventricles and the AV valves and the atria? What we assess if there is one or two ventricles, what is about the AV valve attachment, is there an atrioventricular discordance or concordance? That means are the atria normally connected to the wrong ventricle or vice versa? Is there a dextrocardia, and how to describe this condition? Is there a heterotaxy, as we're going to listen this afternoon, or what's going on? Now, first of all, the easiest is probably you see, or there is an absent ventricle, and the first diagnosis would be probably single ventricle. But for the cardiologist, the single ventricle is another entity. What you see here is one ventricle in a complex malformation, and probably what we will expect the cardiologist from us to know is that this condition is probably the single ventricle. Why? What we have here are two atria, one normal-sized atrium, but one very small with the lung veins, and there is no ventricle here. That means what we have here is a closed and practically absent chamber, and we have a kind of the severe form, this is the extreme form of a hypoplastic left heart with an absent left chamber, combined aortic atresia and mitral atresia, provided that once you go to the great vessels, there is a hypoplastic aorta and you don't see the aortic valve. But this condition rarely also could be associated with the double outlet ventricle. But this is, I want to show you that this ventricle and this ventricle and this ventricle are differently to be described. They seem to be a single one, but no, now I know that after such a course, you should know a little bit more about this. This condition is another one because you have nearly normal-sized atria, because the blood will come to this atrium. This is still used because the blood will go from this atrium toward this one, and this is a left ventricle, and this is a severe pulmonary atresia with intact septum, and this is why there is an absent chamber. Let's say like this condition, but on the other part. Here you have equally sized atria and a huge foramen ovale because the whole blood will pass through the atria and will pass through the foramen. This condition, you have two atria draining with two separate AV valves. You see even the attachment here into one ventricle, a double inlet ventricle, and generally a left ventricle from the anatomy. And if you are experienced, you will look here and there. If you go to the next plane, and you will find some rudimentary chamber because if let's say theoretically you may assume, oh, it is a huge or a practically absent septum as an extreme form of septal defect, but embryologically it's wrong. It is during rotation, let's say a wrong rotation, and there is a rudimentary chamber and there is a VST here, and in general the VST in many conditions, let's say restrictive. This is why it is not a severe form of VST, it is another disease because the AV valves are not draining into the separate chamber but into one, and the other one is rudimentary. But I want to tell you, let's say my first message is, even if you see one chamber, by analyzing the relationship of atria and chambers, you can get to another diagnosis than saying it's a single ventricle. We go to the next, which is the easiest one. I will pass rapidly over. Next, what you can detect is a small ventricle, a hypoplastic ventricle. The difference between these and this one is quite easy because the apex of the heart is not formed by the left ventricle anymore. The left ventricle is so small, is not functioning. But the fact that there is a lumen here means there is no air, there is blood going inside. That means this mitral valve was patent and is now so severely dysplastic that some blood can enter, but it is it's a functional kind of mitral atresia, but it is not closed. There is some blood going inside. You don't see it on color Doppler unless you go for low velocities. The valves which are completely closed, then you will not see a ventricle. This is a severe form. It's easily detectable on one hand, and this one is a form, of course, you can see and detect, but sometimes are the hypoplastic right heart a little bit difficult to detect. First of all, they are 5 times less than the left side. And second, because we are used to know that the right side is shorter than the left, some cases are not so short to be impressively seen. This is why you need the movements before you see that there is no contractility here. But in what I'm trying to show you that if you try to take the midline, there is the discrepancy of the size, and there is a practically non-functioning ventricle here and there, and the difference. Now, is this condition should be called small or should be called rather discrepant ventricle size? I learned over the years with my colleagues of the cardiology I'm working with that if you tell them the left ventricle is small, they will assume it is a hypoplastic left ventricle because this is the condition they know after birth. And the counseling for hypoplastic left heart is completely different than this condition. Now that you are expert, what you see here, the apex of the heart is still formed by the left ventricle, but the size is different. Now, you should know that before birth, half of the blood roughly will go through the right side, the other through the left. That means no one can tell you that after birth, when the complete blood from the lung will pass through the left ventricle, this ventricle will still be small for months and years. It can be, but this is not the typical feature. Cardiology will describe this condition after birth. They will say if there is no problem at the mitral valve level and it's a typical image of an aortic coarctation, the left ventricle will recover because the contractility is more important than the size in this condition. This is why you know now why it is important in this condition not to say hypoplastic left heart. And what you see here is a condition, and this is a patient who came to our center because she said we have the best results in Norwood operation because it needs several operations, blah, blah, blah. I said, no, wait. This is not a condition we'll do in Norwood. The chances are excellent because it's true that the left side is small, but the contractility is fine. The mitral valve is well opening. The color Doppler showed completely normal flow inside and outside. The problem is at the level of the aorta, and it needs not an operation of the heart. It needs an operation from here where they operate only the aortic isthmus and not the heart, and the child can leave home soon after operation. And this changed radically the chances and the prognosis and counseling. My problem is that I'm afraid that some fetuses or many fetuses will be terminated all over places for this condition because they assume hypoplastic left heart. They say in our country and our region we don't operate these and they will terminate. This is why, please don't say hypoplastic if you have a well-functioning ventricle with filling, and especially if the aorta is patent and there is a nice flow. And let's say the secret is two things. First of all, the contractility, and second, the apex. Of course, you may have planes where we are not sure, but it's a completely other image. The hypoplastic left heart syndrome is a condition where the left chamber is not functioning. And here, it seems that it's functioning, even if the blood quantity may be another one. Now, hypertrophic ventricle, I assumed in the past that it should be present on the right and on the left equally, which is not the case. On the right side, you may see it frequently if there is a pulmonary stenosis. In pulmonary stenosis, not in early gestation, but mainly so in third trimester, you'll have a thickening of the myocardium, you may have a bulging, but you rarely have an isolated thickening of the left chamber in comparison to the right one. On the left side, if you have an aortic stenosis, you will not find, let's say, a thickened wall. This is not the typical image you will find. You will find either nothing or it switched to this condition of a critical aortic stenosis, because on the left side, the ventricle will not cope easily with the high pressure. And this is what you see in a case of an aortic stenosis. If we look at right and left ventricle, they will not equally be dilated. Why? I don't know why, but I think that the morphology of the myocardium of the left side and the right side are different, and the morphology of the tricuspid and the mitral are different. The mitral has very rarely an insufficiency. The tricuspid is the first thing the tricuspid will react. And this is why we find a dilation of the left ventricle, but we rarely find a true dilation of the right ventricle. As soon as there is some volume or pressure overload, the tricuspid will be incompetent and it will have a tricuspid regurgitation. This is why you'll find very commonly the sign tricuspid regurgitation with 20 different diagnoses, from anemia to volume overload and so on and so on. But you rarely find a mitral insufficiency or regurgitation in the fetus. And this is also prepared for life, because the right ventricle is not supposed to work for the whole life with high pressure. It works with a normal pressure of a venous flow, where on the left side, this is the ventricle which needs to work lifelong without having any problems. Now, another question is, we have two atria, two ventricles, or do we have one valve, two valves, one ventricle, two ventricles? And these are the typical two extremes. In this condition called AV septal defect, AV canal, we have two ventricles but one common valve. In this condition, double-ended ventricle, we have two valves but one ventricle. So This is why I'm showing you two images. Both are abnormal. You may know the diagnosis when you look at it, but you should think that if you don't know, because you are still learning, if you do it systematically, you are checking, do I have one valve or two valves? Do I have one ventricle, two ventricle? You may reach the diagnosis, because here, this is not a two valve, this is one common valve, as I'm going to show you later on. If you want to train someone in being good in fetal ultrasound, what you should do is what children are used to play. You take two pictures with 7 differences, and you watch them, and you need to find where are the differences. In general, if you've done 20, 30, you know what about. But children are very good. We are not very good because we think too complicated. You say, no, the buttons and so on. The children, they see it because they know how to memorize. The trick in all fetal stuff is that the first image is not present. It's in your brain because you have done 100 and 1,000. And the other image is tilted to the right side. And then you have to put in your brain that the normal and the abnormal, if you put them one over each other, you see the difference. And this is if you are good in display, you know by heart what is abnormal, because you see it looks abnormal, and then you go to diagnosis. I tried to show you this in my in some digital playing. Look at this heart, normal, atria, attachment of the valve, size of the ventricle. And if you move to the next image, what you see here, and return back, this valve is attaching here, the other one is attaching here. The atrium is dilated, and this is the Epstein anomaly. Look at the difference between both. And now, of course, you can say the tricuspid is attaching a little bit lower, but in this condition, it's attaching by far more lower. Of course, not all the cases, the mild case will be detected as easily. In other conditions, you will pass over, but once you use color Doppler, you see tricuspid regurg. In the tricuspid regurgitation, if it's not yet dilated, these conditions is because you see it dilated, but some conditions are not so dilated, and then you see that there is insufficiency, and you return back and you say, do I see the valves? Are they attaching normally and there is a dysplastic valve, or is the valve really more inside here? This is why you should know that the attachment is normal. But this is one part. Another one is this one, by far more tricky, and this is an answer to what Julie was saying. Look at this image, and look at this one. Look at this image. Now what we see here, we see the common AV valve. In AV septal defect, in atrioventricular septal defect, we have in general 3 on the right tricuspid, 2 on the left mitral valve. All are one ring, one valve. And this common valve is typically for the complete AV septal defect because this is the condition. Now, in the 4-chamber view, you will have not 2 separate valve attachments, you have one common valve. And of course, if this picture is so severe, you may see it. But in some conditions, it's not as easy. This is why the severity of AV septal defect is different. Some have a huge defect and some have a very tiny hole. And this is why the secret is not to check always for the VST, but to check for the linear insertion of this common AV valve. And then once the image is magnified, you see here the problem, but it's not always as it is, especially if you look at from the side and so on. But now you know why you are looking for the valve. Because people tell me, I don't need to look for the valve because Epstein, I will see it anyway, it's a cardiomegaly. No, you look for the valves because mainly for AV septal defect. Now, if we recall what we have heard before on systole and diastole, you see here what we have. We have separate attachment of the valves. We have interatrial septum, which is there, the septum primum. And if we look at here the other condition of an AV canal, this condition is so large and 27 weak, you will see it because you don't need any additional things. In diastole, where the valves are open, this gap is very small. And if you don't know this, you will not see it. And this patient was referred because of BPD on the lower centile. It was the 15th centile. I said it was normal, 23 years old. And then this showed me it looks like an AV septal defect. Invasive showed Down syndrome with 23 years old. Now, in systole, however, in both conditions, you'll see that there is a common valve. This is why the message is, look at the common valve. Of course, by using color Doppler, by using these, you may see it. And I think, or I hope, now I show you some what we are going to listen later. In 3D, we may see it easier, I don't know. But I tell you that before you get such images, you know by far all diagnosed, because you need experience to acquire images. But what makes me optimistic is that in the 80s or in the early 90s, color Doppler was something really very, very rare. Nowadays, everyone has color Doppler. It could be possible that one of these days we have easy machine with 4D and screening will be done also with 4D and so on. And it could be easier to see this. But nevertheless, you need to know the basic knowledge before using high technology like color and so on. Now, this is by far more tricky. This image is normal. And look at this one here. We go back. What do we have here? Look at this image. What we have here is spine, descending aorta, left atrium, lung veins, right atrium. Valve attachment, this one is lower than this one. This one is lower than this one. That means the valves are the other way. I told you the valves go with the ventricle. Is this, because it's lower, the right ventricle? Look at the apex of the heart. The trabeculation is on the left, here is on the right. This is the left ventricle. And this condition is this image is called atrioventricular discordance. That means we have atria connected with the wrong ventricle. And this is the typical image you will find in congenital corrected transposition. Of course, you may see some abnormalities in the great vessel, but I want to show you that the images I will show you all may have been done as normal for chamber view, but the specialist knows because he knows the anatomy and knows where to look for. And you see here that you are looking exactly to the valves, and you know that we have valve on the right side lower, we have valves in the same plane, and we have valve the opposite way in an atrioventricular discordance. Now, on color Doppler, believe me, you will not see it because you will do rapidly. You will expect to watch if there is an AV septal defect and so on, but you don't see that the apex is formed by the right ventricle because the color Doppler may appear as a normal image. But if you scan properly, the upper abdomen is normal, the stomach is normal, and look at this image, your first impression would be a critical aortic stenosis because you assume that this is around, but then if you go to the great vessels, there is some problem there. Okay. Now, this is the point where you may need to visualize the papillary muscle. Under normal conditions, what you'll see here is on the left, attachment to the free wall. On the right ventricle, attachment to the septum. Normal. Abnormal. On the left, attachment to the septum. On the right, attachment to the free wall. Believe me, this is nothing you see during scan. This is thing you should look for. You have a suspicion, you say, are there really a switch of the ventricle? Then I can check and I know what to look for because I have all the features. I have the valve, I have the attachment, I have the apex, I have the trabeculation, and then you have done your diagnosis. So, clinical use. 2 fetuses showing similar hearts, both are on the right side, your right dextrocardia, and you see situs inversus, and you are done. It's not true. What you see here is a typical situs inversus with a right ventricle anteriorly, because this is and you see here, this is left atrium with the pulmonary veins, and this is the left ventricle. You go to this one, they appear similar on the first image, but what you see here, this is the left atrium with the pulmonary veins with the septum, but this is a right ventricle. And this is the trabeculation, and this is shorter. That means what you have here in this image is a dextrocardia with an atrioventricular discordance. Next time you will have a fetus with the heart on the right side. You have to check these because congenital transposition, they have often heart, let's say, with the heart on the right side, 20% of the cases. You go to this condition. Now, these seem to be similar because we have both on the right side, both is the right ventricle posterior, but in this condition, Oh, this is the same, sorry? Yeah. Okay, I will go to the next one. The next one is the one more tricky. Okay. So this one is left atrium here, the right atrium here, the right ventricle here, and the left ventricle here. Okay? If you look at the video clip, what you see here is from this ventricle and this ventricle are the vessel arising in a parallel fashion. The large is the pulmonary artery, and this is the aorta. That means the aorta is arising from the right ventricle, and the pulmonary from the left. That means we have a discordance, we have a transposition, but we have also an atrioventricular discordance. This condition is easily called congenital corrected transposition of the great arteries with dextrocardia. So now, if you look at rapidly, you say, oh, I see a dextrocardia and situs inverse, which is not true. Why is this case for me very important? Because this is then when I understood why in the past, when the corrected transposition was called L transposition, it's not true. Because the arrangement of the vessel is not a left one, it is D, because the aorta is on the right side of the pulmonary artery. This means you have a D malposition of the vessels in the corrected transposition. This is why the true term should be corrected transposition and not DTGA on LTGA. Too complicated, but we move. But I'll show you that if you know how to look for, you can see the structure. Now, left atrial appendage, right atrial appendage can be seen. Ideally, Dario will show you at other occasions, let's say conditions where he did this with the inversion mode and with the Sono AVC. Sometimes when I do some 3D, I'm really surprised how good we can see. This is a STIC volume, and you see here, outside of the heart, the finger hook-like of the left appendage and the broad attachment of the right appendage. I'm not sure that on everyday's life we'll do this. We don't need it. Why? When do we need it? Once we have an isomerism, and Julene will tell you about this more in the afternoon. We have two left atrial appendages in this condition. In left isomerism, you have two right atrial appendages. And if you know this condition, you see the symmetry of the atria in left, and you see the symmetry of the atria in right. I had recently a case where I felt very proud. This patient came from Russia, because many will deliver in our in center in Berlin. She came with an AV septal defect, and she told me, luckily, it was not a Down syndrome. So, and this was the AV canal, and then in the next plane, I look at the upper abdomen. What I saw here is double vessel sign, typical for left atrial isomerism. Stomach was on the left, the heart was showing an AV septal defect, there was no bradycardia. And then I went to the heart, and what I saw here are two atrial appendages. In other words, my diagnosis was AV canal as a part of left atrial appendages, and this is why I would recommend you to check for bradycardia until birth. Now, if you go behind the heart here, in this region, we can see some abnormalities. We see the lung veins attaching to the left atrium, and this is what we should look for in some conditions like this one. Fermon will show you this more in the afternoon. This is normal appearing for chamber view. You think the left side is a little bit narrower than the right, but actually not. But if you look at behind the heart, then you realize that spine, descending aorta, but the veins are not connected. There is a kind of membrane between these, and this is a typical image of abnormal pulmonary venous drainage supracardiac. That means we don't see the true connection, because I'm seeking for this atrial septal defect, a condition which is very difficult to be detected on 5 minutes? I have 5 minutes, yeah. So atrial septal defect, we have different groups of ASTs, very difficult to see prenatal. This is why I will not recommend you to write in any time I see an AST, unless one condition, which is the AST of the septum primum defect. The septum primum is the only one you can reliably recognize antenatally, because this part, as showed you with the white dot, is missing. And once you look at the heart during systole and diastole, it is between the septum and the atrium. In this region, there is a gap, and this is the AST. If you use color Doppler, and you should use color Doppler, you see that the flow will pass from the right to the left in almost all conditions. It's important. I'll tell you now why. This is a patient who came to see us last year, had a calculation risk in early gestation 1 out of 1,500. Doctors assumed that the left wall is abnormal and there is a pericardial effusion. And this was the finding, seemed normal. And this was my image. I said, yes, pericardial effusion, yes. And I was scanning the heart. I prefer, in such doubtful cases, to have always an apical approach. Now, the right ventricle appeared normal, the flow was normal. And then in one plane, I saw what is here. And I waited until the fetus turned. And you see the attachment are, let's say, not in the same plane, but what you see here is a gap. And I said, it is an AST. And AST is an incomplete AVSD. I said, you tell me the risk you have. I don't believe I recommend you to have an invasive procedure. And it was a trisomy 21. 1 out of 1,500. Not easy detectable on a normal scan if you don't look at it. But the pericardial effusion may have been a hint to look this for. What you should be careful about is the coronary sinus. The coronary sinus is a vein which collects the coronary veins, and it enters under the heart along the left atrium to the right atrium. Why? Because this condition can mimic an AST1. And it seems similar sometimes, especially when it's dilated. When is it dilated? Mainly in conditions where, this is the normal condition, when the left cava superior is still there and it drains automatically in the coronary sinus. And what we see here in this normal, so-called normal heart, you see on the border of the left atrium, left superior vena cava. It's an additional kind of cyst. If you go lower, because this it does not drain into the left atrium, it goes under the atrium into the coronary sinus, and then it is dilated. If you see this condition here, you have a four-chamber view a little bit lower. You see a dilated coronary sinus. If you use color, the color will show you from this direction to this one. Where in AST, it will go from right to left. Here it goes from left to right because it goes from up and go to the other side. This is, if you look at studies on left superior vena cava and so on, many were assumed to be AST. They seem similar. What is the clue how you get the diagnosis? You go to the three-vessel view, and you have, in addition to the superior vena cava, a left one. That means the three-vessel view will be completed by a left superior vena cava. And if you add color, you see that both superior and left superior will go toward the heart. Now, not all cases, because once you see this, you should rule out AST, and you should also think about a very rare condition we published just now in the White Journal. This was a coronary sinus, dilated, and what was found in the fetus too was an azygos. That means isomerism are related to abnormalities like superior vena cava, but also to abnormal lung vein drainage. This, and we went to the three-vessel view, superior vena cava, azygos, and no left superior vena cava. How comes that the dilated coronary sinus has no left superior vena cava? Then you return back to the four-chamber view, and you see that behind the heart there is a vein, confluent vein, and a little bit lower, you see that this vein drains into this coronary sinus. In other words, it is an abnormal pulmonary venous drainage into the coronary sinus, which is one of the cardiac forms of this one. The first detection was, of course, the azygos, and the second one was the dilated coronary sinus. And then you see it. Otherwise, you will not see such details. But if you are looking in, let's say, with the sharp eyes to every detail, you know what you're looking for. This was only the four-chamber view. I come to my conclusions. I think some things are maybe too complicated, some things may be normal. But you see that such an easy topic like the anatomy of the four-chamber view, you can learn by far more than you assumed. And this is why you should not count the chambers, but by far more you should know the typical sign of abnormalities. I showed you some signs at the level of the ventricle, the apex and the contractility and the shape. I showed you why the attachment of the valves may be important, especially when you have some doubtful cases, and the relationship of the atria to the ventricles, the concordus and discordus, and to atria, and two valves and one valve and also that not only the four-chamber view, but the area behind the heart may be of big importance. And I thank you for your attention.
Thank you, Rabbi.